Hi and welcome to another video. Today we'll be discussing diabetic ketoacidosis. Diabetic ketoacidosis may be the first presentation of someone with type 1 diabetes. It is a life-threatening presentation and it has a mortality rate of less than 5% in younger individuals, but in the elderly it can be as high as over 20%. However, it is important to note that since the 90s, the rate of deaths from diabetic ketoacidosis have steadily decreased in the UK and indeed everywhere else in the world. It is a metabolic emergency in type 1 diabetics, and there are some risk factors to be aware of, one of them being inappropriate insulin therapy, so especially in patients who present with diabetic ketoacidosis for the first time because they don't even know they have diabetes. This would be one of the reasons for the precipitation of the attack. Their body just has not enough insulin, so they go into DKA as a result. The most common precipitating factor for DKA is infection. It causes things like adrenaline and a systemic response to this infection to lead to insulin resistance, as well as increased lipolysis and ketogenesis, which overall contributes to the development of ketoacidosis. However, heart attacks and other cardiovascular events can also provoke the release of hormones which can result in DKA in patients who, for example, already have diabetes. I would like to briefly talk about the pathophysiology of diabetic ketoacidosis. There is insulin deficiency. This could be because the pancreas is being attacked by the body, which is one of the commonest reasons for type 1 diabetics, or there's other underlying conditions, for example cystic fibrosis, which results in the dysfunction of pancreas. As a result, the sugar cannot get into the cells, meaning another way of creating energy needs to be found by the body. The body goes into ketosis and uses triglycerides and amino acids for energy. However, as a result, you get ketones which are produced, and the concentration of those ketone bodies rises the longer the person is using those alternative methods to create energy. This overall causes the blood pH to drop as the ketone bodies are very acidic, and that is why overall in diabetic ketoacidosis you get hyperglycaemia as well as ketonuria and ketonemia and low blood levels, also known as acidemia. With regards to the clinical presentation, there are key things to remember. I use the mnemonic or the acronym PLANT. So P stands for polyuria, L stands for loss of weight, A for abdominal pain, N for nausea, and T for tiredness. However, other key symptoms to also remember are things like a fruity breath or acetones-like breath, confusion, rapid breathing, loss of consciousness, and in some cases even coma. In terms of investigations, some of the key ones to remember are firstly blood glucose and ketone levels. So you will see hyperglycemia and ketonemia, and those are the key ones to measure first when someone is suspecting DKA. Venous blood gas can help determine what the anion gap is, and if it is over 16, it indicates severe diabetic ketoacidosis. Some other blood tests include a full blood count as well as usinase or urea and electrolytes, and you will see patients have hyponatremia, hyperkalemia, and leukocytosis. Lastly, you can also look at an ECG, and that is mainly to see whether there's any cardiac precipitants for a DKA, but also it can show high T waves, which is secondary to the hyperkalemia present in patients with diabetic ketoacidosis. With regards to management, one of the first things to remember is giving them lots and lots of fluid. Patients with diabetic ketoacidosis are extremely volume depleted. They will be extremely dehydrated. So if the systolic blood pressure is less than 90, you should give them 500 milliliters of sodium chloride over 10 to 15 minutes. However, if it is more than 90, it should be 1,000 over 60 minutes. However, you should always check your local hospital guidelines to see what their treatment of diabetic ketoacidosis is, especially when it comes to fluid resuscitation. You should also give insulin, and that is 0.1 units per kilogram per hour based on the estimated weight of the patient. And if the blood glucose levels fall below 14 after initial treatment, you should also resume the patient on a dextrose solution, usually dextrose 5 or 10%, as you want to avoid them becoming hypoglycemic, as that is also very dangerous. Lastly, you need to identify the precipitating factors and perform very regular checks on the blood ketone and glucose levels. This has been a very brief overview of diabetic ketoacidosis. I'm more than happy to answer any questions you might have in the comments. Thank you so much for watching, and I hope you consider subscribing.